So how many of you are familiar? I know Thor talked a little bit about a tumor board. I caught a piece of that earlier. How many of you are familiar with a tumor board? Okay, this is good stuff. People love to see how doctors interact, and with NET care, multidisciplinary care is so incredibly important. And so our NET board is going to share a couple of cases, and they're going to demonstrate how they debate and how they talk about it and how they make decisions for people like you, NET patients. So I'm going to allow all of our board to come up. We have Dr. Assi, we have Dr. Chan, Dr. Clancy, we have Dr. Thor, we have Dr. Kunz, and I believe that is it. So if you guys can come up and
Great. Hi, everybody. I'm Pam Kunz. I am co-directing today with Dr. Jen Chan. I'm an associate professor of medicine, medical oncology at Yale. I focus on caring for patients with NETs, and I love doing these events. So thank you for sticking with us to the bitter end. I thought, I don't know if we have the next case one. Okay. There. I'm going to just define, pull back the curtains on what a tumor board is. You may have heard this term. Your case may have been presented at a tumor board. All of our institutions offer tumor boards. They may be slightly different, but basically it is a gathering of multiple disciplines where I call it one-stop shopping. So one of your doctors can bring a case to the tumor board, and then you get the benefit of input from multiple experts. At Yale, it actually happens virtually. We sort of transitioned to Zoom, and there are about 30 doctors that are on the tumor board. It includes medical oncologists like myself, surgical oncologists, radiation oncologists, nuclear medicine specialists who review DOTA-PETs, radiologists who look at CTs and MRIs. And I just think it's one of my favorite meetings of the week. It is critical to excellent patient care, especially for neuroendocrine tumors. So we're going to pretend that we're a tumor board. And in reality, we kind of have rapid fire discussions, but we're going to kind of go through this, and we have 2 cases to present for you. And so I'm going to present the first case. Dr. Chan is going to present the second case. I'm going to pose questions to our esteemed tumor board. We're missing radiology, so we're going to pretend that we have, I don't know, Dr. Clancy, do you want to be a radiologist?
Great.
Yeah. So we'll all weigh in. So this is a 58-year-old man who underwent a renal ultrasound for a prostate evaluation. He had had some urinary frequency. And then incidentally, so kind of surprise, was found to have a 3.1 centimeter liver mass detected. This prompted an MRI of the abdomen and pelvis, and that actually showed a 5.2 centimeter pancreatic head mass and multiple liver lesions. We take into consideration what other medical issues a patient may have. So he actually had a history of Crohn's disease, which is an inflammatory bowel disease. The workup that was done included, so I'm bringing all this, I'm presenting this to the tumor board. This is almost exactly verbatim what I would say. The patient had a gallium dotatate PET CT. It showed that pancreatic head mass was bright. So were the bilobar, liver mets. And then the patient had a biopsy of one of the liver metastases. It showed a well-differentiated NET, grade 2. Ki-67 was 8%. And then we did an evaluation for functional NET that was negative, no evidence of an inherited syndrome. So what I'm trying to do is pull together all the things you learned today from all the different talks. And so Dr. Clancy, our radiologist, and surgeons are used to looking at, I'm assuming, Dr. Clancy, you look at scans for your patients, right?
Correct.
Yeah, do you want to take, I only have really one slice through each of these, and normally we would run through kind of all of the imaging, but maybe talk to us a little bit.
That sounds perfect. So what we're looking at is an axial view of the MRI on the left side. And what that shows us is is imagine the patient is lying down and we're slicing through the images like a loaf of bread, and we're looking from the feet up. So on the right side of that image is really, the left side is the patient's right side, as if we're looking from the feet up, and vice versa. The right side of that image is the patient's left side. So in the area indicated by that dotted line is the head of the pancreas on the right side. Just immediately adjacent to that, that white area is the superior mesenteric vein and artery.
You're doing a good job.
You're doing a good job. Yeah, that's right. These are important vascular structures that might indicate whether a primary tumor is easily removed without damaging other structures. It sits right above the kidney and vessels to the kidney, but it's a sizable mass in that area.
And there are also some liver lesions.
Right, and so on the right side with the DOTATATE scan, we can see that on the right.
Imagine the patient's, for those of you who've had DOTA-PET, this is looking at the patient like this.
Exactly, in those darker areas above sort of that squiggly area in the middle that represents the pancreas, right above that is the liver, so we see two darker areas in the liver, the right and the left side.
And just to make a comment, we see some normal uptake on a DOTA-PET scan. So the pituitary gland is normally bright. That doesn't represent cancer. The spleen is normally bright. And then the contrast that you get injected gets excreted through the urinary system, and this is the bladder. So Dr. Halfdanarson, so as you're seeing this, you have a patient with a metastatic pancreatic NET grade 2. What are you starting to think about? What else are you wanting? Or what other questions might you have for the tumor board?
Yeah, so right now, we have we've done the diagnosis, we know what we're dealing with, we've completed the staging, we know where the tumor started, where it is. So my next question would be to know, is this what we call a functional tumor? Is the tumor producing hormones or chemicals causing symptoms?
Non-functional.
Non-functional, okay. So then the next thing is really to talk about the treatment. And sometimes the question comes up, do we need to treat at all? But with a tumor of this size, with these types of metastases, I think most of us would be inclined to start some therapy.
What would you start?
So I would, all of these tumors light up like really, really bright. That means that the target for one of our therapies, what's called the somatostatin receptor, is abundantly present on the tumor cell. So I would probably start with monthly injections of a drug called octreotide or lanreotide.
Yep. Dr. Clancy, would you ever go straight to surgery?
For a case like this, for a 5-centimeter tumor, if we did not have any evidence of spread, that was certainly a case where we would recommend surgery. And the evidence with spread, particularly liver, I think it's challenging because we know we do have other options available. And I think also treatment of liver disease after a big pancreatic operation can be particularly challenging.
We also have a pathologist, not on this tumor board, but we normally do have a pathologist. We've talked a lot about pathology today. Dr. Halfdanarson reviewed this. So again, this is just showing, and our pathologists actually walk us through microscopic pictures and teach us a lot about what they're seeing. So this is almost exactly what we would be looking at. So really just confirming this Ki-67 of 8%. So systemic therapy, so either chemotherapy, biologic therapy, somatostatin analog was considered the most optimal approach given diffuse pancreatic involvement. And really there was a thought that the patient would even need perhaps a total pancreatectomy. So given the bulky disease, we actually decided to use capecitabine temozolomide with the hopes of yielding tumor shrinkage. The patient tolerated the treatment very well. However, there was no shrinkage. So this was on the left was the MRI before CAPTEM, and on the right was the MRI abdomen after just 3 months of CAPTEM, but there was really no response. So we took the case back to tumor board, and this can be an iterative process where the tumor board is really intended to be a resource for physicians. And I think that one thing I always like to say, it's really our way of getting other opinions. And what's the saying? If your doctor won't do a second opinion, get another doctor. And I think it represents humility of all of us to say, I don't know, I want input, and you want your doctors to be doing that. So you can always ask, has my case been presented to the tumor board? When do you use a tumor board? And so we really decided, this was a little controversial, Dr. Clancy, so we decided to move forward with cytoreductive surgery. We just felt that this hadn't budged, it was technically feasible, but this was a big surgery for the patient. So I don't know if you have, sometimes these are tricky conversations, but I think another thing that this showed is that we didn't have progression and didn't have new spots. So this 3 months was a bit of a test of time and a test of biology. Dr. Assi, do you have anything to add to this or how your tumor boards work?
Yeah, I mean, as you can see here, there are multiple treatment options that we can consider for patients and different approaches. And really the key here is really the discussion that happens between the different the different disciplines, medical oncology, surgery, interventional radiology, pathology, and nuclear medicine. So, for example, Dr. Halfdanarson thought about giving the patient somatostatin analog. We thought about doing CAPE-TEM as a treatment. Given the recent NETR2 trial, we could have thought about doing Lutathera upfront as well. I mean, all these are different options, and determining it really is based on this discussion that we have amongst ourselves.
Yeah. I'm going to not spend a whole lot of time on this case, but I'm juxtaposing two cases. This was a patient who also had a pancreatic NET and ultimately had a really robust shrinkage or response to CAP-TEM. So I wanted to make a point with this, so I'll show you some of the pictures here. And compared to the last one, you can see very large liver lesions, so there were multiple as compared to the last case. And then after 6 months of CAP-TEM, we had really significant tumor shrinkage. And just to kind of juxtapose these two cases, and Dr. Chan, I might ask you to weigh in on this a little bit. So these two cases, I'm sorry, they're misnumbered here, case 1 and 2. We had one patient with no response and another patient with a response. And there were a number of treatment options, as Dr. Assi said. But how do we know, Dr. Chan, or do we, how can we select patients who are going to respond?
Yeah, for the most part, we really don't have a lot of predictive biomarkers. I think, with the exception perhaps of somatostatin receptor expression, which does help us choose PRRT candidates. But I think choosing between these different options, we really do have to rely a lot on the clinical factors. For example, that second case you showed where there was very extensive bulky disease, our goal really is to try to cytoreduce. So we're trying to, or get major shrinkage. So we're really probably trying to decide between something like chemotherapy or even PRRT. But how people are going to respond and to what degree is always really a bit unpredictable. I think in both of the cases you showed that, one could make the argument chemo to shrink and then to think about surgery afterwards. I think you did some really great work in your ECOG study looking at possible predictive biomarkers for chemotherapy. So maybe we will in the future have some tools that we can use, but they're not routinely implemented right now. And I think that's why this discussion is so important, where we can think about the option, discuss the pros and cons, really try to be on the same page as a team about what we're hoping to achieve, and work together with everybody on the care team to make sure we're making the right decisions.
That's right, yeah. And I'm going to ask one last question of Dr. Halfdanarson, and then I'll pass to Dr. Chan. So is there an optimal order in which we should be using these therapies?
So for a lot of them, there really isn't. And so we don't really have good studies that compare one treatment option to another. So in every case, it just has to be sort of thought of very, very individually. And we take into account other health conditions. There are some people who, let's say, have diabetes who might not tolerate a certain drug, others who have high blood pressure who might not tolerate a different drug. So you have to sort of look at the whole picture. And also, what do the patients want to do? And so no ideal sequence we can debate, and that's actually why we use tumor boards. And the one point I wanted to get across too is that you can go to 2 or 3 different NET centers of expertise and get completely different recommendations. They're all good. and very valid.
Okay, we'll do, if the AV folks can move to case 2. Thank you.
All right, we'll start with a second case or second set of cases, and this is not pancreas neuroendocrine tumor, but we will talk about small intestine neuroendocrine tumors. So this particular patient is a 70-year-old man who went to the emergency room in, now this is going back about 10 years, February 2013, with severe abdominal pain. And during the course of his evaluation in the emergency room, he had a CT scan that showed a mass in the mesentery of the abdomen. He had really not too much past medical history. He had non-melanoma skin cancer, he had a history of kidney stones and hypertension, but otherwise healthy. So this is an example of one of the images from his CT scan. So just like Dr. Kunz showed, this is kind of one of these, what we call coronal views, where you're looking face on at the patient. So the right side, his right side is on the left side of the screen, and what you can see where the arrow is pointing to is this mass that is in the mesentery of the small bowel. So I'm going to stop here and ask the panel right now what your thoughts are. And I'll start first with Dr. Clancy about the imaging. He's got severe abdominal pain and has this mass. What would the emergency room doctors be thinking, and kind of what would you think comes next?
So with a mesenteric mass, there are a few different things that we'll think of, a few different types of diagnoses. So it's usually limited to about 4 things. And we don't see a lot of bowel obstruction. There's really no dilation of the other loops of bowel. And I might be concerned that we have some ischemia to the bowel, or maybe a low-grade obstruction. Typically, I would say the emergency room doctors are going to be thinking of the same thing and ask some consultants to have a look at the case. If I were to see the case, I would first consider that, whether or not this disease could be removed and safely preserve enough small bowel so the patient could avoid intestinal insufficiency. I would point out that many times a patient could be seen in a hospital where neuroendocrine tumors are not treated as frequently. And you might go to the operating room and have a small bowel tumor operated on, and a mesenteric mass like that left behind because it was deemed to be unresectable. And patients can be quite upset about that and say, why did I need a surgery? Why did this person not remove the original tumor? But I view that as very sound judgment to not try to explore or intervene in a situation where you don't think it's safe, because removing a mesenteric mass and getting bleeding can have really disastrous consequences. And it's relatively straightforward to go another time and remove that. So if the patient were not seen in a center where they see a lot of mesenteric disease, I think it's perfectly fine not to rush into the operating room.
So he did have, not immediately, but did have exploratory surgery shortly after that mass was seen. So they found a mesenteric mass that was near the cecum, so that's the first part of the large bowel. They did not see in the operating room any evidence of spread elsewhere in the abdomen, so there was a small bowel resection that was performed. So the pathology, and I don't have slides to show today, but the pathology revealed a well-differentiated, low-grade neuroendocrine tumor that was in the ileum. So that's the last part of the small intestine where we most commonly will find small intestinal neuroendocrine tumors. This was invading through the muscle layer, what we call the muscularis of the small intestine. As we look at grade, they saw only 1 mitosis per this area of 2 millimeters squared. The Ki-67 index was less than 2%. There was, under the microscope, evidence of invasion into small lymphatic vessels, no invasion around the nerves, but they did find a neuroendocrine tumor in 1 of 12 regional lymph nodes. So he's referred to an oncologist for discussion about what to do next. So I will ask Dr. Assi how you would counsel this patient and how you would manage this.
Sure. So yeah, the first thing is really to discuss what we found on pathology with the patient. So it's very important to notice that it's a well-differentiated tumor, and it's a low grade with a Ki-67 that's less than 2%. So it just gives me a sense that this tumor was probably there for a while. It's a kind of a slow-growing indolent tumor that's been there. But that being said, there's also some concerning factors that I see on pathology. So one, lymph nodes was involved, so this kind of ups the stage, so this of the tumor. So because there's lymph node involvement, that's a stage 3 at least. I'll talk more about that. And there's also lymphovascular invasion. These are bad prognostic signs. Now, the next step in my view would be to make sure the cancer has not, to fully stage the patient and make sure the cancer has not gone elsewhere. So getting a gallium-68 dotatate scan would be my next step. I don't know if it's already been gotten.
Great. And then, so it shows no evidence of disease. So he's followed for several years with routine clinical visits, scans. Oftentimes it's a yearly CT scan of the abdomen, pelvis, just to make sure there's no evidence of recurrence. So about 6 years after the surgery, he has staging imaging. And on the CT scan that was done, there was a 3.5 centimeter lesion that's in the left lobe of the liver. This wasn't seen in the year before. There's also some smaller lesions in the liver that were too small to characterize. So we had an MRI of the abdomen that showed, again, this mass that's in the left lobe of the liver, measuring 4 centimeters. And they saw a few other smaller lesions that were just millimeters in size, but also concerning for possible areas of spread. He had a PET scan that showed intense uptake, a gallium dotatate PET that showed intense uptake in that left lobe liver lesions, and a smaller amount of uptake in these other lesions. This is just an example. The CT scan is on the left side of the screen, and the arrow is pointing towards the mass, which you can also see on the MRI. Some of these other smaller lesions on this particular sequence of the MRI, you can see, and they're kind of a bit scattered through the liver, but very small, very peripheral. So I'll stop here and ask the panel, starting with Dr. Clancy again, what your thoughts are about this particular case in the liver metastases.
So based on the, usually I would look at the distribution of lesions and try to determine if this is a tumor that could be removed surgically. And it appears as though from this scan that you could easily remove the larger tumor and treat the other smaller tumors, which should be visible on intraoperative ultrasound. We have, in this case also, the benefit of some tincture time. So we know that it's been some time between the original tumor and the development of liver metastasis, indicating that it's probably a bit more of an indolent process and hopefully would respond well to local therapy.
So that's exactly what you did. So this is the PET scan again showing the uptake in the liver lesions. So he had a robotic left lateral liver resection. I think some of the other smaller areas of disease may have either been removed, or sometimes we will leave and watch those areas. Something about that larger mass suggested different biology than some of the other lesions. So it was I guess the goal here was to remove the largest areas of disease. So this pathology showed a metastatic, well-differentiated neuroendocrine tumor. It was a grade 2 tumor. The mitotic count was 1 per 2 millimeters squared, and the Ki-67 index was almost 15%. So I'm curious, Dr. Halfdanarson, how you would think about management now. So he's had the larger lesion removed, and all that's left behind might be a few small areas of disease.
So it looks like the larger lesion is a little different biology. So I would really be careful with watching a little bit more closely. Maybe not annually, but maybe every 4 to 6 months for the first 2 years. So you can now have the discussion about whether you should start any therapy or observe. And so I think that's a discussion we have to have with the patients. There are some people who would feel very comfortable watching this. I think there's a very, very high chance something is going to show up, or the smaller lesions are going to grow to a bigger size. But it would be reasonable to wait a little bit and not do anything. It would be every bit as reasonable to start the injection therapy right now.
So in this particular case, we opted to watch, and about a year later, we started noticing that some of these other smaller areas of disease were starting to grow. So here's now the MRI of the abdomen again. So there's one of the liver areas, and there's a few others that you see scattered. So this is, I think, at the point where we decided we would start somatostatin analog therapy. Let me see. And then a year later, we started to see continued increase in size and number of liver metastases that showed now still somatostatin receptor expression on the dotatate PET, but there also was evidence of disease involving liver and bone. So here's a sense of what the liver lesions look like. You can, if you remember what it looked like before, now it's a little bit larger, and you can see some of the areas of disease in the bone. So the tumor board would now discuss what to do next, and I'm curious, Dr. Kunz, and this will be our last question, what you would do at this point.
So this is a patient now with a metastatic small intestine NET who's had progression after cytoreductive surgery and a somatostatin analog. So the question, this in sort of doctor speak, we'd talk about this as second-line treatment for patients with metastatic disease. I would probably consider using lutetium dotatate or Lutathera for this patient. We know that it has kind of an excellent ability to stabilize growth. About 1 in 5 patients had some amount of tumor shrinkage.
That's exactly what we did, and patient is doing well. So this is really just a summary of all that we talked through. Again, small intestinal neuroendocrine tumor, that initial presentation with abdominal pain showing the mass that ultimately led to resection of the primary tumor and mesenteric disease. And as Dr. Kunz just summarized, he's had resection, he's had systemic therapy, and some of the other considerations that I think we would discuss at the tumor board was whether to do a liver-directed therapy, or at what point we might want to consider other systemic therapies like everolimus. And then we didn't talk a lot about it because the patient did not have any symptoms, but the other important consideration is whether there's carcinoid syndrome. So I will end there. I hope that was a helpful run-through of how we approach these cases and think about these issues at our tumor boards.